Hello, my name is Dr. Sherry Chou, and I want to thank Professor Mejia and all of the organizers for the opportunity to speak at the NeuroLily Conference 2021. I will be talking to you about COVID-19 and cognitive disorders, specifically delirium and encephalopathy. Here are my disclosures. I receive research funding from the government. So let me start by reviewing some of the very early reports we have of neurological injuries and involvement in COVID-19. As we remember, the first time the world came to know COVID-19 was through this manuscript that was published online in January of 2020, from first report from China. And even in this first report, amongst many of the other impressive images of the lung and symptoms, we see that there's a mention of confusion. And in this very early report, 9% of the patients who presented with the very first cases of COVID-19 presented with some sort of confusion. A few months later, their neurologists took a look at a collection of patients, a total of 214 patients who were the earliest patients in the world to have corona disease of 2019. And they similarly described a proportion of patients who have impaired consciousness. Out of all of the patients who presented, 7.5% had this condition, and it could present anytime between 1 to 25 days after initial diagnosis of infection. Since after that, the wave moved on to Europe, and in one report from Strasbourg, France, that was published in June of 2020, in intensive care patients with severe lung disease and ARDS, they noted that agitation and delirium is a very common finding, as you can see by the CAM-ICU score. 40 out of the 58 patients screened positive for agitation. In the same group of patients, they also looked at some MRI findings, and they noted that there might be leptomeningeal enhancement, suggesting some sort of inflammatory process in the brain. But very interestingly, of the 7 patients who received a lumbar puncture to look at their CSF, none of them had positive PCR for SARS-CoV-2 virus in the cerebrospinal fluid itself. Since then, there are many bigger single center and single nation data that have emerged. This is the biggest single center data from the United States back in 2020, coming out of Northwestern University by Dr. Liara and Dr. Batra. And in this study, they looked at 509 overall patients with coronavirus disease who were admitted, and they found that encephalopathy was by far the most common presentation, the most common neurological dysfunction in these patients who were sick enough to require hospitalization. And they were even able to take a look at the different predictors to see which patients are most at risk at encephalopathy. And in this particular cohort, by far the severity of their COVID-19 disease was the strongest predictor for developing encephalopathy. But similarly, a history of neurological disorders and chronic kidney disease also were important risk factors. Around the same time, a United Kingdom-wide national surveillance study came out, and they lumped all of the neurological and encephalopathy and neuropsychiatric symptoms together in one group. And the other group that they looked at are cerebral vascular diseases or strokes. And as you can see in this figure here, they noted that of all the patients who had neurological symptoms from coronavirus disease, it seemed that the neuropsychiatric symptoms may affect the younger patients here in the orange bar, whereas the cerebral vascular diseases may affect the older patients here, showing in the blue bar. Right around that time, and for the rest of 2020, many additional papers came out that described delirium and encephalopathy in various different patient populations from various regions of the world. I mentioned Strasbourg. We had a very large study coming out of Brazil, and a couple of studies out of Italy. And some of them were done in geriatrics wards, where they studied particularly the older patient population. What I want to point out to everyone is look at the definitions of delirium and encephalopathy used here. And I will come back later to address this in my talk. But as many of the experts in the audience would know, delirium and encephalopathy are actually not, they don't have a clear definition that is, universal and worldwide. And so people get at this diagnosis by various methods. But it looks like no matter how you define delirium and encephalopathy, and for the rest of my talk, I will put them together. I'm not suggesting that they're the same thing, but because of the way we capture them, we might be delirium and encephalopathy may end up being the same things in these papers. No matter which way we define them, you can see that the number of patients with COVID-19 and with delirium is prevalent. And in multiple studies, they show that if you have delirium with encephalopathy, with COVID-19, these patients have a much higher odds of dying in the hospital, and as well as beyond. One study out of Strasbourg specifically looked at MRI findings. This has not yet been replicated by any other studies. But the key take-home message here is, at least in these single center or regional studies, it seems like there are many patients with delirium. Some are in the ICU, some are hospitalized, some are in nursing homes. But in all of these cases, delirium and encephalopathy seems to be a mortality predictor. This will bring me to share with you the first report from the GCS Neuro-COVID Consortium and the Energy Consortium. And this is the global combination of two global worldwide consortia putting their data together, putting our data together to maybe give us a first look at what exactly COVID-19 means in terms of neurological impacts, and specifically about delirium and encephalopathy. I will quickly introduce the GCS Neuro-COVID Consortium and our global partners here. The GCS Neuro-COVID itself is a global consortium. We're unique in the sense that we have studies in both adult as well as pediatric populations. The data I will show you today is all pertaining to the adult population. Our pediatric studies arm, led by the pediatric investigators, are actively in the process of analyzing their first interim analysis. And we're very honored and grateful to have wonderful global partners, particularly the European Academy of Neurology and their energy network, which has greater than 200 and probably 250 sites now in multiple parts of the world, including Europe and Africa, but beyond. Also very honored to have the Latin American Brain Injury Consortium, LABIC, and the Possible Network. And thanks to the investigators, thanks to all of our global partners, the combined network has over 450 registered sites, and we're endorsed by the Neurocritical Care Society, which is also a global society. This is only a map of the GCS Neuro-COVID Consortium and the global spread of the consortium. Imagine on top of that overlaying the Energy Consortium, which is also global, as well as LABIC and Possible. And as you can imagine, we cover many parts of the world, with the exception of Antarctica. And these are our global partners, and particularly Professor Mejia, who leads the Latin American Brain Injury Consortium, and Professor Kurtz and Shinto Tsutka, who lead the Possible Network, as well as our EAN, European Academy of Neurology partners. And together we've published the rationale of the study, how we were able to harmonize our data elements in multiple publications, and specifically in this particular one, the development of case reports. Thanks to our Latin American global partners, we were able to translate our case report forms into multiple different languages, including Spanish and Portuguese, as well as develop them for both adult as well as pediatric populations. And these data use forms are published so that they're free for everyone to use and for their own studies. So let me come back to the GCS Neuro-COVID Consortium and tell you quickly what the interim report may show us about what we know to date about delirium and encephalopathy. So in this first report, we were able to use both a retro and prospective look at cohort studies, and 28 centers out of the entire consortium from 13 different countries were kind enough to send us their data. And because of this, this is really the first report that allowed us to look at the impact of COVID-19 on neurological symptoms from March to September of 2020. So really in the early phases of this pandemic. This is an adult population study, and neurological symptoms are defined in two ways. One is what patients can self-report, but the second one is what we are able to clinically verify in the case that the patient's unable to self-report for various reasons, and our primary outcome is in hospital mortality. In this study, there are three major cohort types that are included: the energy registry, and then two different cohort types from the GCS NeuroCovid. What you want to understand from here is the only one that is a population study is this one on the right, what we call the all COVID cohort. This one includes everybody who come into the hospital over a period of time who are diagnosed with COVID, regardless of whether or not they have neurological symptoms. The other two cohorts have a neurological entry criteria. So you have to have COVID and also be identified as having some sort of neurological dysfunction to enter into the cohorts. The energy registry is even more stringent. They require informed consent because they follow patients long-term even after hospital discharge. And their case ascertainment were done by trained neurologists, so probably more precise than the GCS NeuroCovid Consortium. This is a breakdown of just a global spread of this initial report. And as you can see, I outlined the one that is actually a total cohort study of all COVID patients. And that's also the largest cohort. In this cohort, for this interim analysis, we only had the US sites reporting. But for all of our other cohorts, you can see that we have global partners reporting in as well. And overall, you can see that the patient characteristics are not surprising. About a quarter of these patients, 25% approximately, are on mechanical ventilation, are in the ICU. The one thing we were able to capture that other studies didn't look at is, of all the COVID patients, how many of them have pre-existing neurological disorders? And as you can see from the numbers here, it's not low. It's at least 23% from the general COVID cohort of everybody who has COVID, and it goes up from there to the neurologically focused cohorts. So now let's take a look at the neurological manifestations. What we saw was that neurological manifestations are in fact very common. If we combine both self-reported symptoms and clinically verified symptoms and syndromes, 80% of all the patients who came into the hospital who were hospitalized with COVID had something. If we limit it to only the clinical syndromes that need to be verified by a clinician, still over 50% of all of the COVID patients admitted to the hospital has some sort of neurological syndrome. Of all those syndromes, by far the most common one is some sort of delirium and encephalopathy. So once again, in this particular cohort, where we included all of the patients who with COVID who were admitted to the hospital, 50% of all of those patients had some sort of encephalopathy or delirium during their hospitalization. And you can see that the coma is the second common. And surprisingly, encephalitis and meningitis, something we were very afraid of at the beginning of the pandemic, is actually one of the most unlikely diagnoses or least common syndromes. And here in this graph, it just goes to show that encephalopathy and coma, some sort of disorder of disturbance of consciousness, is by far the most common symptoms we identified, regardless of which cohort of patients we look at. So, but what does this mean for patients? Here we looked at what acute neurological manifestations are there and their impacts on the inpatient mortality. And very simply, I can tell you that having any sort of neurological syndrome increased the patient's odds of dying in the hospital. If they had a clinically verified neurological syndrome, that increased odds is almost 6 times higher than people without neurological syndromes. If we look at the specific neurological syndromes, acute encephalopathy or delirium, patients with that have more than 5.5 times higher likelihood of dying in that hospitalization compared to patients who did not develop encephalopathy. Not surprisingly, let me go back. If you look at coma, the odds for dying with patients with coma are even higher, but the proportion of patients in this group is lower. And if we look at the epidemiology of these syndromes, and specifically acute encephalopathy, you can see that there's not much of a difference between male and female. The proportions are similar, but if we look across age groups, the incidence of acute encephalopathy steadily goes up, especially once you are beyond 60 years old. Beyond 80 years old, 3 out of 4 patients develop some sort of acute encephalopathy. So our work is far from done. What I have presented to you was really just an interim analysis that we were able to perform in the end of 2020, year 2020. Since then, we have had the full data set submitted by many of our additional partners. So in addition to the 3,700 patients I presented to you earlier, we now have additional data from over 9,000 patients from all over the world. And we're very, very grateful for our partners, and our global partners. And for the first time, we will have data reporting in from Colombia, Mexico, and Canada included in this data analysis. We're actively analyzing this data and hope to be able to share this with our friends and colleagues very soon. But let me say a word about encephalopathy and delirium. Here's the thing about it. It is a clinical syndrome, but it is definitely not one disease. There are many ways these patients with COVID can develop delirium and encephalopathy. We could postulate maybe the virus can directly invade the nervous system, such as herpes simplex virus or West Nile virus. There's a whole class of para-infectious immune-mediated autoimmune encephalopathies and encephalitides. I list the examples here. We don't know whether there is one with COVID yet, but there's a lot of studies ongoing to try to search for this. And we should stay tuned about that. In addition to that, there are many neurological complications of systemic disease. So for the patients who are very, very sick in the ICU, we know that COVID increases your risk of clotting, and patients can develop ischemic strokes. Patients can have hypoxic brain injury or complications from sepsis. So patients can develop encephalopathy from just being very severely ill. Patients can also have exacerbation from a pre-existing neurological condition. So the epileptic patients may develop increased seizures. Patients with neurodegenerative and neuropsychiatric disorders may have an exacerbation. And finally, the medications that we're giving people to try to treat their COVID may also have impacts on the central nervous system and increase the incidence of delirium and encephalopathy. So what is it? Well, this is one of the earlier images published by the Strasberg group, where they noted these microhemorrhages on MRI diffusely in all parts of the brain in their severely ill ARDS patients. Is this a signature for COVID encephalopathy? I would tell you that we don't know, but we have seen this before COVID, because we know patients with ARDS can develop these findings on MRI. Since then, one of the groups at Mass General, led by Brian Edlow, have gone in with detailed high-field MRI, but also did an MRI radiology and pathological correlation study of the patients who died of severe COVID. And as you can see in a similar pattern, they describe these deep, small petechial hemorrhagic lesions that are seen on high-field MRI. And when they cross-compare this with gross and microscopic pathology, these do indeed represent little areas of petechial hemorrhage. We don't know the mechanism, we don't know what they mean. And Dr. Nath has since then also published evidence, again, radiographic and pathologic correlation studies, where they found microvascular injury in the brains of these patients. And in these patients in particular, you can see that there is sort of edema and leaking of fluids outside of the capillaries, as you can see here by the fibrinogen stain. But when they look at the collagen stain, it looks like these microvessels are intact. So the vessels themselves did not rupture and broke, and they're not broken. In addition, they have these interesting immune stains to show that there is a collection of CD68 positive macrophages and an attraction of lymphocytes to the perivascular location, as well as sort of these strange perivascular astrocytosis that we're still trying to explain to this day. Finally, so there's some evidence of microvascular injury, there's some evidence of hemorrhage, but what about emboli? So here's one more very interesting paper, again published from Northwestern University by Dr. Liada and Batra, where in real patients who are alive, they listen in with the TCD to try to detect emboli. And in these patients with encephalopathy, you can see that both the MRI and TCD suggest that there might be microemboli actively flowing through the circulation of these patients. Again, do all of these things suggest to us that we understand encephalopathy? Not necessarily. And as the GCS NeuroCovid Consortium, and these are investigators, we're continuing to search for this question. And I just want to take a minute and acknowledge our steering committee. And thank you all for your attention, and I will take your questions. Thank you.